Thank you. At the outset, I would like to thank the Asia Pacific Academy of Ophthalmology for making me a part of this important session. I would be talking to you about fungal keratitis, the management algorithm. There are no financial disclosures. So I think for any case of microbial keratitis, it is important to know geographically where you are located. Just to give an example, in northwest India, it is aspergillus, which is common. In southeast India, it is fusarium, which is common. The classical features of fungal keratitis are known to us, like dry, thick, raised texture, feathery margins, satellite lesions, endothelial plaques, fixed hypopyon, and abscess. And demetricious fungi can have brown pigmentation, and fusarium tends to have a severe course with deep extension of perforation, and yeast has a collar button configuration. 10% KOH remains the mainstay for a diagnosis of fungal keratitis, and cultures have to be sent on Sebrot's dextrose agar. And even if the clinical picture appears to be that of fungal keratitis and microbiology says otherwise, you can do PCR and you can do confoscan to see whether hyphae are present or not. We've also looked at the role of spectral domain anterior segment OCT in fungal keratitis. It's especially useful in posterior abscess because it does document the infiltrate size, epithelial defect, posterior abscess, areas of necrosis and cystic spaces, and areas of necrosis corroborate with the activity of the fungal keratitis. Of course, this is going to be covered in detail by Dr. Prajna in the next slide. The medical therapy, 5% netamycin remains the mainstay for a case of fungal keratitis, which is given hourly during the daytime, 2 hourly at bedtime. And if there is worsening, then we add another drug, which could be amphotericin B or voriconazole, and therapy lasts for 3 to 4 weeks. Cases of fusarium keratitis resolving to topical netamycin, an example of this, which resolves on it. Now, topical antifungal therapy does have limitation because of poor ocular penetration, bioavailability, and toxicity. And the mycotic ulcer treatment trial 1 by Dr. Prajna's group did show that voriconazole should not be used as monotherapy in filamentous keratitis. Systemic antifungals have classically been given for large, deep ulcers, scleritis, post-PK, fungal keratitis and endophthalmitis, and we like to give either ketoconazole 200 mg BD or voriconazole 200 mg BD with liver function tests every 2 weeks. This is an example of a large ulcer which was also deep, which responded to topical netamycin and systemic ketoconazole. And another case which we published of tunnel fungal infection which also responded to topical and systemic voriconazole. Now the MUT trial 2, again by Dr. Prajna's group from Arvind Eye Hospital, looked at the role of oral voriconazole on fungal keratitis and did recommend that fusarium keratitis cases may benefit from the addition of oral voriconazole to topical netamycin. And we did do a randomized control study at the same time where we compared oral voriconazole versus oral ketoconazole as an adjunct to topical netamycin in severe fungal keratitis. And as far as the ratio of tear film concentration was concerned, there was a difference, but in terms to duration of resolution of infiltrates, there was no difference. Cases with systemic voriconazole fared better and significantly as compared to cases with ketoconazole as far as the tear film by serum concentration is concerned. These are the 2 cases from the same cohort treated with topical and systemic ketoconazole and topical and systemic voriconazole. Targeted drug delivery does have a role, especially in recalcitrant ulcers, both intracameral and intrastromal. Intracameral for those cases which do not respond, have thick hypopyon, endothelial exudate, deep anterior chamber exudates. And voriconazole 50 to 100 microgram per 0.1 ml can be given. And of late, we've also started using netasol, that is the soluble form of netamycin, as intracameral and intrastromal agent both. This is a case just to show the response on intracameral amphotericin B. Intrastromal injections are given for deep mycotic non-perforated corneal ulcers not responsive to conventional topical and systemic antifungal therapy for 4 weeks. This was our very first paper on intrastromal voriconazole. Subsequently, we did do a randomized control study which showed that topical voriconazole seems to be a useful adjunct to netamycin in fungal keratitis, which does not respond to topical netamycin alone. In this study, however, the intrastromal injections did not offer any beneficial effect over topical therapy in the sample on the cohort that we enrolled. These are 2 cases of topical natamycin and topical voriconazole which healed on therapy, and 2 cases where topical natamycin was given along with intrastromal voriconazole which also healed on the therapy. Now, this is the way how you give intracameral and intrastromal injections. So mechanically the exudates have to be washed first because otherwise the drug will get mixed up with this, followed by the injection of the intracameral voriconazole and intrastromal voriconazole, wherein one generally uses a 30 gauge needle, goes 5 to 6 hemimeridians all around the lesion to form a barrage from an area which is clear, from an area which is not thinned out, and the reflex is pretty much the same of the phacohydration wound. The mycotic antimicrobial localized injection did show that the intrastromal injections in the primary treatment did not have any role. Again, a study which was initiated by Arvind Eye Hospital. Now, this is the management algorithm for fungal keratitis, that is the TST protocol, or the topical, systemic, and the targeted therapy protocol, where we looked at 223 patients of fungal keratitis prospectively, and this is essentially what we derived. If the ulcer size of the fungal keratitis ulcer is less than 5 millimeters, less than 50% stroma involvement, start topical natamycin. If there is no response, you can add either amphotericin B or topical voriconazole. If it is more than 5 millimeters in size with more than 50% stroma involvement, start topical and systemic both. If there is no response, add topical voriconazole. And if there's no response after 4 weeks, give intracameral or intrastromal or both, depending upon where the exudates are. Now, this is something which we worked on, and the good news is that now we found a company to make this. We call this as Natasol, which is nothing but it is the soluble form of natamycin, where natamycin is being linked to a polymer to make it soluble. And this is how it looks like on scanning electron microscopy, and this is how it looks like when in bottles. Looks like a clear solution, and we have now patented this as well. And if you look at the pharmacokinetics in single dose kinetics as well as in multi-dose kinetics, it compares favorably well, in fact, superior to the natamycin suspension 5% solution. And we did again publish our results on intrastromal natamycin or intrastromal natasol in recalcitrant fungal keratitis as a pilot study. And subsequently, we compared the safety and efficacy of intrastromal injections of voriconazole, amphotericin B, and natamycin in a randomized control study. These are some of the cases from the same study. This is intrastromal natamycin or natasol, which is causing the resolution of the ulcer. Yet another case with intrastromal natasol. A case with intrastromal voriconazole, subsequently again another case with intrastromal voriconazole, and this was a case of post-LASIK fusarium keratitis, again which responded to intrastromal voriconazole and underwent optical penetrating keratoplasty at a later date. Now this is a case with intrastromal amphotericin B, and this is the overall comparative picture. So in terms of healing, there was no difference between the 3 injections, but in terms of vascularization, the amphotericin B cases did have more vascularization, both in terms of depth as well as the quadrants when you compare with voriconazole and natasol both. These are some of our review articles on mycotic keratitis, which were published for the detailed for the details that you would want to see. A word of role of collagen cross-linking in fungal keratitis, and as of now in fungal keratitis it doesn't have too much of a role. Again, this was corroborated by the study from Dr. Prajna et al. PDT does have a role to play in treatment of fungal keratitis, and world over there are studies and trials which are being done, and I'm sure very soon we would have a conclusive answer on this. Now, we did study the outcomes of use of cross-linked donor corneas in therapeutic penetrating keratoplasty in fungal keratitis, and the cross-linking of the donor corneas was done. And this is, of course, in a limited sample size, but the findings were very interesting in the sense that those cases which were cross-linked did better as compared to those cases which were not cross-linked prior to use of the graft. Deep vascularization was observed more in the non-cross-linked corneas as compared to the cross-linked corneas. The best corrected visual acuity was also better in those cases where cross-linked corneas were used, and this was also corroborated on the confocal microscopy, where the stromal keratocyte density on confocal was significantly less in the cross-linked corneas. As far as cross-linking is concerned, exact protocols need to be defined. Fluence needs to be worked out. You need to work out whether riboflavin, rose bengal, or any other dye that has to be used, and UV rays or other cross-linkers have to be looked at. Therapeutic keratoplasty has to be done when everything, of course, fails. And post-operatively, generally, topical steroids are given after epithelialization and are withheld for 1 to 3 weeks. And the topical antifungals do continue. Sometimes it's a multi-prong attack, such as this. So for a case for which therapeutic keratoplasty was done, for a recalcitrant case of fungal keratitis, you had to give intrastromal injections also because of recurrence of the infection. And again, these are our review articles on fungal keratitis. This is how the healing of the corneal ulcer should be in general, unlike this where you have sequel and complications. So to conclude, geographical variation does exist in fungal keratitis. Netamycin is the drug of choice for fungal keratitis. Additional topical antifungal therapy may be added. Targeted therapy and systemic drugs may be given in recalcitrant cases, and surgical management may be required for cases not amenable to medical therapy and injections. And sometimes one size doesn't fit all, which means you need a multi-prong attack because the bugs are smarter than us. Thank you very much for your kind attention.